What number of backlogs and surgeries do hospitals have across South Africa before COVID-19 and as a result of delays caused by COVID-19? How can surgical care be better coordinated in South Africa, and what steps have been taken to deal with backlogs? Hello and welcome. I'm your host, Dr. Musam Tombeni. Signing with us today is Ntabiseng Ndlovu. Based on the health department statistics, more than 107,000 non-emergency or elective surgeries were put on hold during the pandemic. But challenges in addressing surgical backlogs have been there before COVID-19. On Vital Signs, we'll focus on surgical backlogs in South Africa. Coming up on the program, we'll listen to healthcare workers who participated in the Rural Health Matters outreach program that alleviated surgical backlogs in Limpopo province, and we'll also listen to patients from Pelonomi Hospital in Bloemfontein about the delays in surgeries that they experienced. We'll speak to a young man who was in a car accident in the Limpopo province that required a surgical procedure that he couldn't get help for as he needed it, and we'll speak to the Limpopo Health MEC about how the province is solving their surgical backlogs, as well as the Gauteng Health MEC about their plans to end these surgical backlogs. Lastly, we'll speak to the president of the Association of Medical Councils of Africa about their role as regulators, as well as the AMCOA International Conference that will be taking place from the 2nd to the 6th of October 2022 at the Sun City Resort in the Northwest. Remember that you can be part of the show by asking the guests that we'll have on any question that you may have on your mind by simply sharing your view with us on what we're discussing. The number to call is 011-714-0677 or 011-714-0678. Also available on social media, that is on Twitter at SABC Vital Signs or Facebook SABC Vital Signs. The show continues after the ad break. Welcome back kuyo-ke i-Vital Signs. Namhlanje sikhuluma ngama-backlogs akhona, ama-surgeries all across i-country yethu, nokuthi-ke ama-department wona-ke lawo specific ayenzani ngaleyo nkinga. Now, the Limpopo Health Department initially targeted 200 patients during the Rural Health Matters outreach program aimed at clearing a surgical backlog in the province. Now, Limpopo MEC for Health has extended her gratitude to healthcare workers who participated in the Rural Health Matters outreach project that alleviated the surgical backlog in the province. Take a listen.
We managed to go and reduce our backlog. We have reduced the backlog from February next year to November this year.
So we are happy to be part of this project of Rural Health Matters. Women walk around and having urinary incontinence and they become outcasts.
The conditions can be very, it can take your self-worth away. So imagine somebody that had a perfect life and then after the birth of their children, they start leaking on a daily basis. They would have to wear sanitary pads. They often are not able to leave the house for that condition. It's a hygienic problem. It's an intimacy problem with their partner. And the thing is, people don't talk about this problem because it's embarrassing, right? You don't want to talk about the fact that you're peeing your pants or that there's something coming out of your vagina.
What this has done was sort of give us more edge in what we do normally, you know. Learning from other specialists as well, and you know, little tips and tricks of how we can be more efficient in what we do, and also just the encouragement, you know, to say what we've been doing is good work, you know, and that we are on the same level as, you know, international and national doctors in the field.
When he came from Canada to come and operate this 20, I think we are at 21 as we speak now, but we're still continuing, aiming at 26. As we speak now, 21 patients have been operated with his skill. Yes, 21 patients have benefited, but there are more patients who are going to benefit even when we left, because it's leaving us with the skill. We have managed to give information about this condition, not only to the patients, also to the doctors. Our workshop, lucky enough, it was connected virtually, where the doctors were able to access and see this procedure done from the remote area. Where many doctors or health workers now, they know that this can be treated. Other than that, we managed to go and reduce our backlog. We have reduced the backlog from February next year to November this year.
31-year-old Mokgethi Maluleke from the Limpopo province landed in hospital after a horrific car accident that left him with injuries that required surgical procedures. Now, due to broken equipment, Mokgethi couldn't get the surgical procedures that he desperately needs. And of course, his condition has sadly deteriorated. He joins us now to talk about this condition and, of course, about the help that he actually needs. Good day, Mokgethi. How are you today?
Good on yourself.
Good, good. So let's talk about the accident before we get into the injuries. Tell us about that horrific day in your life.
That was very bad, because accident, you can't plan accident, it just happened. So, yeah, after the accident, my life changed to worse, because lots of things I can't do it for myself, because and worse on that it was my right hand, because I'm using right. So now I must learn to use my left. So, yeah. That's the story of my life.
So the accident happens, Mokgethi. You find yourself in hospital. They tell you that you've got injuries to your right hand. What specifically do they say is an issue? Is it a broken bone? Is it tendons that aren't working? And what procedure do they actually have to do that you haven't had as yet?
It's broken bones on my shoulder and my elbow. So I need operation. So firstly at the CN at the CN Patrulli, they said the problem was the C-arm was broken at that time. So that's why I couldn't get the operation that is needed. So during that time, and then because there's nothing I could do, and then they discharged me. So they said they will call me once the machine is fixed. So because of I needed the help, so I contacted one of my friends here in Mpumalanga. I said, no, the C-arm is working here in Mpumalanga. So I asked for a transfer to Mpumalanga. Then when I get there, and then they assist me, but towards going to the operation, so the same thing happened. The machine is working, but now they're having a problem with the specialist. They say the specialist is not supposed to come because they don't have specialists in this hospital. So they are borrowing specialists from other hospitals to come. So they come once in a month to operate people. So once you miss that deadline, or once they do 2 people or 1 people and not on the list, must wait for the next month. So even now, I'm still waiting.
So let's talk about timelines. I mean, when did the accident happen and how long have you been waiting for all these surgeries?
I've been waiting for 3 months now.
Sure.
Yeah.
3 months. So 3 months ago was the car accident, and since then you were into the hospital in Zanin. You haven't gotten assistance because I'm assuming the C-arm is still not functional at that hospital. You've tried to go to Mpumalanga as well to get help there, and that specialist comes once a month rather. Are you on any list are you waiting for this elective procedure to happen anyway?
Yeah, at the moment they said on the hospital they want to employ their own specialists. So I'm still waiting. This on the 5th, I must go back and check if ever the specialist is there yet or not. Then after is where they can give me the date for the operation if the specialist is there.
And this is in Mpumalanga?
Yeah, in Mpumalanga.
And in Limpopo?
In Limpopo, because I've asked a transfer to come to Mpumalanga, I didn't require it back. I didn't get the feedback back. I didn't inquire back because now I'm here because I'm working in Mpumalanga. So that's why I needed to be close to work.
So let's talk about your condition currently. I mean, you mentioned that the injury was to your arm. I mean, you've mentioned shoulder as well as, broken bones in the arm as well. In terms of functionality, are you able to function? I mean, what is your daily job? What do you have to do? And do you actually need to use your arm in your daily job?
Yeah, on my daily job I need to, but I can't. So I'm now on the light duty. For instance, at work I'm on the light duty job. I can't perform because I'm a welder. Welder needs both hands functioning. So At the moment, I can't do my job. So I'm on a light duty job, which means everything is down. It's less light duty, you understand?
No, I
So
understand.
it's not that easy. It's not that easy. Yeah.
So what would you like to happen? In an ideal world, what would you have seen this situation pan out to be for yourself?
Operation would be helpful for my situation, not only for me, but for everyone that's in the situation, even though we don't know how long and what process needs to be done. But in this kind of situation, it's not easy or it's not nice to stay in this situation for a long time.
Okay. Well, thank you very much, Mr. Maluleka, for chatting to us today with respect to the sad situation that you find yourself in. I really hope that you, over the next little while, are able to get the assistance that you need so that they can sort out your problems and you can go back to full functionality and not have to worry about being on light duty and things such as that. I mean, important information being outlined here, and of course, looking at this idea that people actually have jobs that they need to do. Then they have lives that they have to live. And of course, addressing all their surgical issues or addressing their health issues in general will obviously help them achieve the best level of health that they can get. And that was Mr. Maluleka, all the way from Limpopo, chatting about his story, of course, with the results to that accident that they had about 3 months ago. Moving on, Limpopo Health Department gets surgical backlog up to date. Now, a team initially committed to operate on 67 children with various health challenges, of which 45 were in Mankweng Hospital and the rest were in other facilities in Limpopo. Now, Limpopo Health MEC Dr. Phophi Ramathuba has been leading a team of specialists and subspecialist doctors who are obviously distinguished experts to clear this patient backlog at these hospitals in Polokwane. This initiative under the Rural Health Matters Outreach Program aimed at complex surgeries that include urogynecological, urology, as well as, with all of this happening, having a transfer of skills to clinicians in the province. To elaborate more on this program, we're joined by the MEC, Dr. Phophi Ramathuba. Thank you so much for joining us today. I think it's important to have this chat around your program, but before we get to that, let's get an understanding of what you think is causing this backlog for your province.
Good morning, Dr. Musa, and morning to all your viewers out there. And really, we appreciate the opportunity you've given us to clarify some of these issues. What we need to appreciate, especially when it comes to orthopedics cases. Orthopedic cases, as long as on a daily basis, you, as the media house, it's announcing about so many fatalities on the road. You must remember that for every 2 or 3 fatalities in an accident, there could be 5 to 10 who require hospitalizations and operations. So it's going to be very difficult to say when can you clear the surgical backlog, especially looking at orthopedic cases. What I can reassure the people of Limpopo is that we currently are dealing with the current cases. And it's unfortunate, the case that you were dealing with here, which I'm going to be following up, I don't think the patient was correctly advised. The CM does not operate. CN Patuli, it's a level 1 district hospital, which he should have been referred to Letaba Hospital. And since that time, he would have been operated long time ago. I can guarantee him here and now that if he was to come back to his district, which I am currently here today, I'm in Kapane Hospital. I will be going to Letaba Hospital. Over the weekend, from Friday to Sunday, we have done so many orthopedic cases with the visiting professor, Steve Machidze, and a number of, especially some from University of Pretoria, from Shalom Matleke. They do come to assist us during these rural health matters. So I'm just saying the solution is here. We do have permanent specialists. In Letaba Hospital, there's a full-time orthopedic surgeon. But like I've indicated, because orthopedics cases are happening every hour, it becomes difficult to clear the backlog. But the rest of the surgical backlog would be ranging from one, the shortage of the skills. Look at your cataract. This is one procedure which Dr. Litlape will agree with me as an ophthalmologist. It will not necessarily take 30 minutes for one person to be operated. But we still have got a lot of backlogs because we don't have ophthalmologists, especially within the public sector and also within the rural areas, wherein the majority of our people, for instance, in our province, 91% of the population is dependent on the public health care. So all these other procedures, it would be as a result of you running short of skills. Secondly, as a province, for instance, we do not have a single central or an academic hospital. We currently utilize Mankweng and Petersburg Hospital as our tertiary hospital. They've got limited number of theaters. So we have recruited so many medical specialists, but unfortunately, the competition, when you have booked Mr. Maluleke for an orthopedic case and a gunshot or a stab wound comes in, the cardiothoracic surgeon will say this is a life-saving operation and will have to postpone or cancel Mr. Maluleke. If a pregnant woman or an ectopic comes, you will have to cancel the elective or the plan. So that is what is continuously making that these backlogs continue to be there. The limited resources that we're currently having, and both even including the human resource that we really need as provinces.
Now, an important thing here, I think, is understanding what the aim of the Rural Health Matters program is all about. So take us through what came about this idea, and of course, what is the main aim? Which procedures are you looking to really lessen the backlog on?
I think what we did, I remember it was in 2020, after the whole hard lockdown first, when COVID-19 wave gave us a breather. It coincided, there was, I think it was in August, where how it started here. It's clinicians who were saying, because MEC, the 15th is your birthday, what present do you want? And my plea was to say, if I can get 50, initially I said the elderly women to be operated on their cataract, that will be enough. And on that day, we found more than 200 patients waiting to be operated. That is when we sat down and say, look, there is in no way we can continue as if it's business as usual, because the rural health equally matters. People in the rural areas, they equally deserve healthcare services. Now, we then started to say, on a monthly basis, we're gonna spend a week. In a week, we are going to be recruiting medical and dental specialists. What we do, we will target you, Musa, and say, Dr. Musa might be working as the head of department in Krisani Bara, but Dr. Musa originates from Hachikunda Marem. He has got the link, those are his people. We then request your services to say, just give us 1 weekend of your leave to come and give back to the community. What we do is to make sure we provide all the equipments that you need, we provide the theaters that we need, we deal with your logistics, and all these professors and even medical and dental specialists who participate in this program, they do it we don't pay them. We only deal with the issues of logistics for them. They're doing it pro bono. That's why we're really appreciating to that. Since we started in 2020, we have already operated. The last time when we were in Waterberg, Bila, the famous Bila, we had already done 4,700 cases since 2020. And now when we move this time around, we are in Letaba, as I've indicated, from Friday up until we are in Maputa Malakis, Kororo Hospital. All the rural hospitals, they are now busy. As I'm speaking here in Khapane Hospital, the general surgeons are there in theater currently, dealing with those surgical backlogs. So when we are done here, next month we're moving to Capricorn District. Then the other November will be going to Wembe District. December will allow clinicians to rest. By doing that, we have seen a number of those who have been waiting for operations, because when we started in 2020, the cataracts backlog that we were dealing with were as far back as 2013. Someone who has stopped working, a young man could no longer work because he was not able to see anymore. But then when I checked this month, where are we? We are dealing with cases that were diagnosed from May, June, July. So moving from 2013 backlog to currently dealing with 2 months to 3 months backlog. This has really made a dent in trying to. We have not yet achieved what we want to achieve, but we are really proud of the progress that has been made by this current Rural Health Matters project.
I think the program is highly commendable, especially when you give us statistics and numbers such as that, where tons of people have been assisted. But I think a big issue that comes with it is that there are lots of people that will then want to participate in this program. So what criteria do you use to pick the people that will get procedures and then, of course, leave others out?
This is where the major problem is, because what we believe should happen is that each and every hospital, when you have a patient consulting and you know that you are a medical officer, you are a level 1, this requires specialist care, it is important for you to refer the patient to a regional hospital or tertiary. Then, based on the availability of the bed and the theater time, they will then decide whether you will be operated at that time or not. If they are not able to operate, they put you on the list, and then you get on a waiting list. So each discipline, for instance, we were busy with the ENT surgeons in Letaba this morning. Their list, it's around 50 children that they are currently busy with. These are the children who have been consulting and were given dates. They are on our system. Of course, we are worried that this whole program also gets to be abused, because some of the people will then jump the queue by coming in, which we are also working with the police so that it should not still work against the people that it has been meant for. This is a project that has been solely meant for the patients in our province who have been on the waiting list for a very long time, and we want that to stop. So if somebody comes from wherever or bribe their way up and jump the queue, we are now putting system measures in place to try and check to say, you can't come here because you have access to Dr. Ramathuba, then you must jump the queue, so that everybody, when it's their right time to be operated, they should be. But mainly, the project, it's being guided by the current waiting list. There's no discipline that doesn't have its own waiting list. We work based on that waiting list that we do have.
With respect to the waiting list that you currently do you have an outline maybe of how far back that is? I know you've mentioned that you're probably about 2-3 months behind with respect to the waiting list or the number of people that still need to be seen. But at what point will you term this project a success or no longer having these backlogs?
You see, we will be able to call this project a success when, especially on orthopedic cases, we're only dealing with fresh cases. You see, if someone got involved in an accident last week, we are operating them this week, we will then be saying we have really made progress. But if we still are operating people who have been involved in an accident 2 weeks or 3 weeks back, we still believe that we are behind. In cases like your cataracts, we are simply saying once a diagnosis has been made that this is a cataract, you must immediately get operated. That's when we will say things are working smoothly. You know, Dr. Musa, we are saying let's measure ourselves, but even though we know resources are not the same. When a person like me and you with medical insurance today get involved in an accident, we get operated on the same day. When I start to see blurred vision and I'm diagnosed as cataract, I don't even spend 24 hours without the ophthalmology having restored my eyesight. So we're saying this is what must happen to the people of this country, so that it should not depend on the size of your pocket that you get access to healthcare. Everyone who needs healthcare, it must depend on how we triage you. If you are an emergency, you must get emergency services. If you are a chronic, you must really wait until your time. If it's an elective, you must wait until your time. But what I can say is that the project, like you have seen our urogynecologist there, Dr. Mwaba, where during the weekend that we spent with the visiting professor from as far as Canada, for instance, Professor Kruger, who was attracted by this while he was born in the Western Cape, but he's currently now in Canada. He has decided to give his weekend all the way from come and serve. You heard they're saying their backlog was up to April next year.
Let me see, I'm going to have to interrupt you sadly, but we've run out of time, unfortunately. But look, it's been great to hear about this program. I think you've done really great work with it, and, you know, reducing all these times for all these people is highly successful. Continue doing all the hard work that you have. That was Dr. Phophi Ramathuba, the MEC for Health in Limpopo. After the break, we'll listen to patients from Pelenomi Hospital in Bloemfontein about their delays in surgeries as well as their experiences. Stay with us. Patients at the orthopedic ward at Bloemfontein's Pelenomi Hospital are complaining about delays in surgery. Some say that they've had to wait for more than a month without being operated on. They also say sometimes they go for over 3 days without food. Now, patients say that they've exhausted all avenues and have nowhere else to turn to. Let's take a look.
A cry for help? Patients have now lost hope over healthcare practitioners of Pelenomi Hospital. For many, it has been a nightmare. Samuel Ndakakatsi is one of the patients who have been waiting to undergo surgery for a longest time. For him, it's been hard to bear.
On the 1st of February, they admit me. On the 17th, they said I must staff for 3 days. I staff. I did listen what they said to me. After 3 days, they canceled my operation. They didn't tell me why they canceled my operation. On the 17th, they said to me I must staff again for 3 days. I do the same thing. I didn't eat for 3 days.
Kabelo Mokgethi is a grade 10 learner who has not attended school this year as he is waiting to be operated on.
So all I want is to be operated so that I can attend school. They are telling me that the year is still long. I will catch up.
Patients say the situation is dire and want to go back home to their families. They are hoping for an immediate intervention. She says they haven't checked me. After that, they put cast and I've been waiting until today.
I started in Botshabelo and I was told to rather come here. It was on the 13th of January. Up until now, I am still waiting to get help. My doctor put me in the ward from the 2nd until now. Some other people who found me here have left.
Health department admits that it has a challenge of staff shortage. They say they have taken other patients to Albert Nzula Hospital to speed up the process.
I tried to get the management of the hospital to attend to this, explain them. And they did explain to me that, you know, there are people that would be scheduled for an operation. And on the time, because they don't eat the previous day, by the time they get to the operating theaters, they are then cancelled because a much more serious emergency has come through.
The Department of Health says there is backlog which is caused by prioritizing life-threatening operations. Aphumelele Mdlalane, SABC News, Bloemfontein.
After the break, we'll speak to Dr. Nomathemba Mokgethi, the Gauteng Health MEC, about their plans to end surgical backlogs. Stay with us. Welcome back to Vital Science. Gauteng Health MEC Dr. Nomathemba Mokgethi says the department is working hard to reverse the backlogs for surgical procedures in Gauteng. A majority of health facilities have been overwhelmed by a series of challenges, including the long waiting list for surgeries due to recent power outages, shortages in beds, bed linen, as well as equipment. And this, of course, has resulted in a waiting list of at least 12,000 unattended surgeries across the healthcare categories. Now, joining us to talk about plans to end these surgical backlogs is MEC for Health in Gauteng, Dr. Nomathemba Mokgethi. Thank you so much for joining us, Doc.
Thank you, Dr. Musa. Good morning to yourselves and your viewers.
So I think let's start off by asking what some of these big issues that have contributed to the backlog are that you've realized and recognized on your end.
Okay. No, thank you very much, Dr. Musa. I must say COVID impacted negatively on the health services, especially on addressing issues of surgical backlogs. Now we're sitting with a backlog of 2 years in all categories of surgeries that we supposed to do. So I know that there was a time when COVID gave us a breather. We then met as a department and we're planning to have a blitz in one of the hospitals. But after we could not even implement, the plan was there, but we could not implement. We went back to other levels of COVID. So we, after COVID, we then have to sit and assess what is it that we can do to be able to address the backlog. And we then discovered that Bara had the highest number of surgical backlogs. We had to analyze and see what are the issues. One of the issues is the one that you have mentioned of a shortage of linen that was caused by boilers that were not working. And then we then had to communicate with or request a DID to assist us in terms of fixing those boilers. And we have a plan with the reprioritization of budget to put a new boiler because those boilers are very old. I think they were put way back in 1981, 1982. So you can just imagine every time we have to wash the linen, we have breakages. So we are planning to buy one new one, which will cost at the range of close to 20 million. So with the reprioritization of budget, we will be able to do that, and it will assist us a lot. And then we have also tried to fix, one of the reasons was also the ailing infrastructure. You find that in some hospitals, they do have theaters, but those theaters were not in a good working condition. Maybe they had problems with the coolers or one or another thing. So the clinical manager is currently going around and trying to fix where we can fix, and then where we can be able to open these theaters. For example, we managed to get an extra theater at Charlotte Matreke, which is operating now. We've extended the working hours. And then during COVID, we had opened one at Bethakloa, and then we were managing to address only the emergencies because that was in the middle of COVID. But now, since the numbers of COVID are very low, we've increased the hours now. There is more hours, like maybe we used to do once a week, now we're doing 3 days a week. And at Bara, we also upgraded one of the theaters. Instead of us having 4, we now have 5. And then the 5th one focuses on cesarean section to address those. With regard to orthopedics, I was listening to Dr. Phophi. It's also a challenge with us. That is the one that has the longest waiting period when it comes to orthopedics. So we have increased theaters as well to focus on that. Last week, we had a challenge at Sebokeng Hospital. So we had to go to Kopanong Hospital. They had a theater there, and then it was not working. So we have fixed that, and we have since operated more than 10 patients. So we're really trying very hard to make sure that we address that. And remember, Bara is the hospital that has the longest waiting list, simply because their catchment area is big, and other provinces are also referring their patients to Bara for different operations. And I must commend Lerato, because even in the middle of COVID, they were trying to address issues, the cataracts. Patients could access cataract operations, and they, to date, I think they are sitting at more than 7,000 cataract surgeries that were done.
Sure.
We have also increased that to Lenasia South and Southern. We fixed our theaters there, so patients can also be able to access a cataract surgery at those hospitals. And then when it comes to Pretoria, in Karaua, we have also approached OD Hospital so that we can be able to have their theater fit there so that patients can also access operations there. So we had a session yesterday, and we have a very good relationship with the universities. Yesterday, we had a very good session with SMU, where they are also saying if we can be able to fix some of their operation, their theaters, they can be to do some of these operations there.
Dr. Mokgethi, I'm going to jump in there just for a second. We have a caller, Mokoena from Gauteng. Mokoena, good day. What's your question?
Ntate wa tsana ke lakang mo Department of Health. Ke laka our government Department of Health ha e tshware batho hantle ne.
Okay.
O thola hore ha o ya go disipetlela mona. I've been in hospital for the whole year this year, up and down ne. O thola hore mole re fihla mole go di security ke pele security ba tla o tseba o tshwere ke eng o etsang o tshwere ke eng. So you have to be unprofessional hore na o tswere ke engwe tsala jwang ka wena from o batla o sokodisa engwe e nyontshang ka o fitisa ya go di sepetlele tsa government go na le ntho ba etsang ba re le ya pampa le fihla mo o thola o tshiya teng o fihle ka bo tshiya teng e telele ne o thola o maybe batho ba tsetsang ka onka batho di high blood pressure di sukela o kry le hore batho ba mo o thola maybe o setsa batho ba i4 how re kena ka re manese a tloka up and down ya di yonche na we sala jwang wa bona he so na I suggest re ka ne re kopa go be le batho ba checkang go di hospitals tsa rona re na ba sebetsi ba di hospital ba sebetsa jwang.
Okay, Papa. Ralebo, I think he told the question now, Papa. I think the question from Mokoena really encompasses around the idea of human resources. Specifically for the surgical backlogs, very quickly, we have about 30 seconds left. What are you doing with respect to capacitating the human resources that are available or what you would need to help out with these backlogs?
Okay, thank you very much. Maybe just quickly to respond to Date Mokoena. I think when you access the hospital, it's, when the security is maybe asking you questions, it's not asking you about your condition. It's just for them to direct you to the relevant department so that you don't waste time going from pillar to post. And with regard to the long queues, I had been visiting some of the hospitals and clinics. I think Dr. Musa, you can agree with me. Our health facilities are really overburdened. To give you an example, in the previous financial year...
We're out of time, MEC. Unfortunately, we're out of time. But I think, you know, looking at what we're talking about today and what you've done over the past while has really addressed the big issues that the province does have with respect to the backlogs. But importantly, what we will see in terms of the future, we're seeing that the theatres are getting refurbished and getting fixed. The theatres are being opened up. More staff is being brought on board to address some of these backlogs. And hopefully, successfully, we will have these surgeries being done. And of course, these surgical backlogs being cleared. We're going for a quick ad break. And of course, that was Dr. Nomathemba Mokgethi, the Gauteng MEC of Health. We'll see you after this. Welcome back to Vital Signs with me, Dr. Musa Mtombeni. The 24th Association of Medical Councils of Africa, AMCOA International Conference, will address the full range of issues and challenges now facing the regulatory authorities globally. Now, under the theme, the health workforce of the future and its regulation, the conference will host health regulators, academics, health professionals, policymakers, and members of the public with the aim of facilitating an exchange of information and meaningful collaboration amongst health practitioners, regulatory authorities, which will provide provide the development of concepts and new approaches in healthcare practitioners regulation. Now, the conference, will take place on the 2nd to the 6th of October 2022 at the Sun City Resort in the Northwest, South Africa. Dr. Phophi, who is the president of the Association of Medical Councils of Africa, talks to us via Zoom from the United States of America about the role of Association of Medical Council of Africa, regulators, as well as the conference. Good day. Thank you so much for joining us.
Good morning to you and the viewers.
So let's jump into it. Before we talk about the conference and things such as that, I want to talk about what the AMCOA does. What is the role of of the AMCOA?
The AMCOA is a voluntary organization of the medical regulators in Africa. So all the statutory bodies in countries that regulate the medical profession are members of AMCOA. In South Africa, the member of AMCOA is the Health Professions Council of South Africa. In Kenya is the Kenyan Medical and Dental Practitioners Council or Ghana Medical Council. We have 24 members in Africa, mainly the Anglophone countries, and we're now slowly moving into Francophone Africa and Luso Africa, and we will be making inroads into North Africa.
What is the purpose of the association, Doc?
The purpose is to support each other and to sharing of knowledge. And we come up with protocols that all the members are expected to implement in their own course, in their own countries. And one of the ultimate aims is to be able to have a borderless Africa, where we can synchronize accreditation of training institutions, we can synchronize assessment of candidates, and we can have a common exam, so that when people are registered with one council, there's recognition in another country. You don't have to write exams because you've taken care of that at the front end.
Now, I've spoken to this idea of regulators. To the common person that's sitting at home, what is the role of a regulator?
Well, we are responsible for accreditation of training. So if anybody wants to start a medical school, for example, it has to be accredited by the regulator. We would then set up the staffing norms and the facilities that are required, the ratios of student to tutors, that the facility is appropriately equipped, that it will be accredited for what it produces. We will accredit undergraduate medical education, but we will also accredit postgraduate medical education. And remember, for postgraduates to produce specialists, you then also have to require the appropriate facilities and the appropriate staff to be able to train those members. So that is one function that we have. We then also have the function of approving the curriculum that the students need to go through. So that we can set the competencies that are required to be registered. We then recognize those institutions that we have accredited, and once you have a successful degree from that institution, it would qualify you for registration. We then keep the register of practitioners that are allowed to practice. We also define the scopes of practice of those practitioners. Some regulators would also keep where the practitioners function so that the practitioners can be located. We are then also expected to ensure that the practitioners upskill themselves. As you know, medicine is an ever-increasing body of knowledge. So continuing medical education is important, and professional development, because we move into a discipline of lifelong learning. So the regulator is also responsible to ensure that the practitioners continually update their knowledge. They are then also responsible for protecting the public in terms of making this information available to the public. But we are, importantly, in relation to the public, responsible for the behavior of practitioners. So any complaints about practitioners registered with a relevant council is lodged with council, and council has a duty to investigate, follow up, and resolve those matters. Discipline of the profession is also the responsibility of council.
Okay, so from the 2nd to the 6th of October, you'll find yourself in the Northwest, where everyone, I guess, that is involved with the association will be there and having a discussion around certain themes at the conference. What, importantly, is the theme for the year? And, of course, what are you looking to get out of the conference?
The important theme is looking at human resources.
Okay.
Living in a digital era. Are councils ready for governing today? Are we utilizing technology? Are our curriculums relevant to the problems of today? Are we supporting practitioners? One of the key things where councils have been weak is in ensuring an enabling environment for appropriate ethical behavior of our practitioners. So we will be discussing the issue of staffing norms. Everybody talks about burnout globally. One of the things that COVID has brought out is the fact that most healthcare professionals work in unfavorable working environments. And one of the issues that I also forgot to tell you is that we also have what we call associate membership in the organization.
Okay.
So even though the primary members are those that regulate the profession, anybody that has a nexus to medicine can register. We have associate members that are Allied Health Professions Council of Rwanda, the Nursing Council of Kenya. So anybody, and we have international organizations that are also members of the organization. We have ECFMG, which is an education commission for foreign medical graduates, which is in the US, which is a member, for example. So our membership is not just about councils, because remember, the care of society, the responsibility lies with healthcare teams, not just doctors. So we are looking at the welfare of the healthcare team. Are we taking care of our people? There are people that are living medicine because of the atrocious working conditions, the long working hours. Something that councils have neglected is the issue of ensuring that the staffing norms are appropriate and adequate. You've just been talking to the various MSCs about backlogs of operation. That's inadequacy of infrastructure, insufficient human resources, poor planning, and not enough budgets for the front line. Those are issues that we will engage with. One of the key features of this conference is the fact that the Ministry of Health of South Africa will be engaged with us. The Minister of Health will be there, the DG will be there. We even have the Minister of Health of Namibia attending. We had other ministers that were invited from other jurisdictions that could not attend because of logistics. So we are now want to be prepared for our roles today. We can see the disparities in terms of healthcare in societies from the different LSMs. We want to discuss those issues. So the key issues of the outcomes of the conference will be revisiting common accreditation platforms, common curricula, common assessments, but more importantly, the well-being of the practitioners. So they work in an environment where they are able to exercise their ethical duties. Everybody complains about how rude we are, but nobody talks about how overburdened we are and that there are insufficient human resources. We need to discuss the issue of the fact that most of our countries in Africa do not have enough human resources. We're losing our healthcare professionals to OECD countries. How do we make our working environment attractive so that we can choose to stay?
Dr. Letlhaphe, I'm going to have to jump in there, but I think we got the last word as you were ending your sentence there. Good luck for the conference from, of course, the 2nd to the 6th of October happening in Sun City, and that will be the conference happening over there. Dr. Letlhaphe, of course, highlighting the important things that need to be done by healthcare professionals and, of course, making sure that we live in a borderless state, I guess, where healthcare professionals can practice and, of course, help out where they need to help out. Thank you so much for joining us over the past hour as we looked at very important issues that will affect you. We'll see you again next week. From me, Dr. Musa Mthomeni. This is Vital Signs.